Welcome to the webinar on the Scholastic Student Athlete Safety Act and what you need to know. Today you'll learn from a cardiologist how to screen your student athlete for silent cardiac conditions so that you can be more confident in recognizing them and knowing when to refer for assistance. In this webinar, we will emphasize key concepts you are required to understand to be compliant with the Scholastic Student Athlete Safety Act. I'm Dr. Cheryl Kamek, co-founder of My PDR Care Partner. We truly partner with pediatricians and primary care providers in the communities we serve. We offer curbside consultations at any time, priority access to appointments, and most patients are actually seen within 3 business days, but occasionally by 7. We have several locations to serve you. Let's get into it. So, the Department of Education released this memo in 2024, and it emphasizes that for providers, you must conduct the pre-participation physical examination after being having completed the cardiac assessment professional development module. This applies to physicians, physician assistants, nurse practitioners, and any provider who does pre-participation physical examinations. For those of you who have not yet done it, you can scan this QR code and it will take you exactly to the location. Today we'll cover the key features needed to be confident that you'll know the material. We will cover 4 key factors: sudden cardiac death incidence, the athletic heart, its characteristics, the key features of dynamic auscultation and distinguishing hypertrophic cardiomyopathy from aortic stenosis, and we'll also touch base on when to refer to pediatric cardiology. We will break this up into a few parts. Part 1 is 15 minutes. It covers facts and stats. Pardon that. So we'll talk first about sudden cardiac death incidence. So here's a question. The chance of sudden cardiac death occurring in an individual high school athlete is A, 1 in 100 per year, 1 to 200 per year, 1 in 20,000 per year, or 1 in 200,000 per year. What do you think? Well, if you answered D, you are correct. The incidence is 1 in 200,000 per year. Fortunately, this is an extremely rare event. Let's look a little bit at the conditions that are linked to it. Most commonly, hypertrophic cardiomyopathy. 36% of those athletes who die suddenly are related to hypertrophic cardiomyopathy. And please note that there is a intermediate diagnosis of LVH with possible hypertrophic cardiomyopathy that contributes to about 8% of the events. The other substantial contributor is coronary artery disease, when there is an anomalous origin of the left coronary artery that passes between the aorta and the pulmonary artery. The problem with this is when you exercise, the blood vessels become enlarged normally, and then they cause compression of the coronary artery that passes between them. Patients present with chest pain during exercise or immediately after, and sudden cardiac arrest. Myocarditis is a contributor. Myocarditis is about 6% of patients. And then there are a host of other players that we won't get into very much today. You need to understand the definition. The definition of a sudden cardiac death is sudden cardiac death is unexpected failure of the proper cardiac function, usually about 60% of the time. It's the heart, during or immediately after exercise without trauma. So during or immediately after, they extend that to approximately 1 hour. So if the event happened within 1 hour of the exercise, it's still considered sudden cardiac death, falls into this category. Now, let's check some facts about hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a genetic disorder. I think we all know that its incidence is not that uncommon, about 1 in 500 persons in the general population. So it's fairly common. Over 300 gene mutations are involved in the sarcomere proteins, and it's usually autosomal dominant trait. It has variable phenotypic expression and it may be delayed in certain families so it can skip generations. In addition, it may be a de novo mutation. So even if there's no prior family history, it can still be the issue. We need to be checking 3 generations of family history because it can skip and it can be a de novo mutation. Let's talk a little bit about the athletic heart and its characteristics. So the athletic heart, it really changes based on the type of activity that they're doing. Endurance athlete versus strength training versus combined athletes, the heart modifies itself normally. These are physiologic normal changes to accommodate the exercise. So the hemodynamic demands of exercise drive the specific cardiac changes. So, for example, endurance athletes, that is, dynamic isometric training, their heart develops a volume lobe, and that leads to eccentric LV hypertrophy. Usually, it's biventricular and biatrial dilation with preserved systolic function. The diastolic function is also normal in these patients. So a dilated heart with normal systolic and diastolic function in a rower, cycler, cross-country skier, and swimmer would probably be physiologic normal changes as long as no other concerns are there. Now, strength training athletes present in a different way. This scenario is a pressure-loaded ventricle. Think the wrestler, the weightlifter. So there's a pressure-loaded ventricle. You get concentric left ventricular remodeling. Wall thickness is usually normal to upper limits of normal. In absolute terms, it's typically less than 12 millimeters, but there is a disproportionate increase in relative to the size of the cavity. The normal right ventricle and the right atrial dimensions are there. So mostly it's confined to thickness of the left ventricle walls and very minimal, if any, LV dilation. That is the strength training athlete. Last category is a combined athlete. They tend to have thicknesses that are, they're both thick, so a ventricle hypertrophy as well as dilation can occur in those. Where this one, the strength training athlete, they can mimic a significant degree. They can mimic the hypertrophic cardiomyopathy patient because the wall thickness tends to be a bit higher than your intermediate measurements. Those they can actually be confused with the intermediate measurements that we see in hypertrophic cardiomyopathy patients that don't quite fit into the category of hypertrophic cardiomyopathy but are still abnormal. So they are a group that sometimes needs further attention to determine if it is abnormal or normal. One key feature, though, is that they have normal diastolic function. That remains normal. Even though the ventricle is hypertrophy, the diastolic function is still normal with them. Last one is the combined athlete. We'll come back to this now. There is thickening of the LV walls and LV dilation, so a combination of changes that happen. These are all constantly being looked at and compared to what we would see in pathologic changes, like in hypertension, thickening of the LV walls but no dilation early. Dilated cardiomyopathy, they have thinning of the walls and decreased function. And then hypertrophic cardiomyopathy, which is thickness of the wall, they don't have dilation and they have diastolic dysfunction. So those are the key features we use to distinguish them. You should be aware that there are many normal changes that occur in athletes from their 12-lead EKG. There are normal findings. So if you send a patient to us or to any cardiologist, you may get some of these reports, and they are all considered normal. Increased QRS voltage. Uh, they sometimes meet criteria for LVH or RVH, incomplete right bundle branch block. Early repolarization abnormalities like ST segment elevations, T wave abnormalities, T wave inversions, even in the precordial leads, as long as the kid is less than 16 years of age, you having inverted T waves that could still be normal. Ectopic atrial or junctional rhythm, first degree AV block, and even Mobitz type 2 can be normal in athletes because they have remodeling in the heart that is driven by parasympathetic nervous system, and it actually slows the conduction through the heart. Bradycardia, sinus bradycardia is also very common. So borderline findings, if there is left axis deviation, left atrial enlargement, right axis deviation, right atrial enlargement, or complete bundle branch block, if you have two or more of these abnormalities, then that quite requires us to do further evaluation. You should always send these patients for referral. So here's a question. True or false? 20 to 30% of individuals with hypertrophic cardiomyopathy who have sudden cardiac death have had prior symptoms of chest pain, dyspnea on exertion, or palpitations, lightheadedness, or syncope. What do you think? True or false? Well, the answer is true. Many of them do present with these symptoms, but as you notice here that many of these are common complaints. But when they are happening in association with exercise, they should be taken seriously and evaluated to the fullest extent as indicated. We're going to switch gears now, part two. We're going to talk a little bit about dynamic auscultation. This part takes about 5 minutes. Stick with me for this. So, first question. The cardiovascular physical exam includes auscultation of the heart to detect, evaluate heart murmur. Auscultation should be performed with the student in which position? Supine, standing, Valsalva maneuver, or all the above? Well, I hope you selected all of the above, because right here in the pre-participation physical exam, right at the bottom, in the middle, sorry, in the heart exam, it tells you exactly what you need to do. Auscultation should be conducted with the Valsalva maneuver, supine, and standing positions. Now, the location and intensity also help you focus on if this is pathologic. So we're going to cover that a little bit too. So physical examination can be an effective screening tool for aortic stenosis and hypertrophic cardiomyopathy. Now, kids do get aortic stenosis. The most common abnormal valve in a child and adult is a bicuspid aortic valve. It's actually one of the more common congenital heart defects. And those bicuspid aortic valves become stenotic, and they can start to develop that process in the adolescent years. So they want you to understand that that does happen, and that these murmurs can sound similar to hypertrophic obstructive cardiomyopathy. I would love for you to go to these sites, take a listen to aortic stenosis and the murmurs of hypertrophic cardiomyopathy to understand better what they sound like. But just to go over this a bit, in aortic stenosis, you typically have a crescendo murmur. It's a late peaking harsh murmur located at the right upper sternal border, right at the aortic valve area. Radiating to the carotids, there can be a delayed single or paradoxical split of the S2. That is if it's pretty severe. It doesn't typically, it's not that dynamic. It can be, um, but in general, it's a fixed obstruction versus hypertrophic cardiomyopathy. Now, if you recall the murmur of hypertrophic cardiomyopathy, it can become more accentuated when you are standing. So it is actually loudest when the chamber is empty. When the LV is half empty, the walls collide more with each other, and the anterior leaflet of the mitral valve gets sucked in. I say sucked in. It's like a negative vacuum, and it gets pulled anterior into the left ventricular outflow tract, causing obstruction and a louder murmur. That is what the murmur is primarily from. You can also have some degree of a fixed obstruction with hypertrophic cardiomyopathy, but the dynamic one is due to that forward motion of the anterior leaf of the mitral valve that blocks the outflow tract, and it is louder when the chamber is empty. This occurs during Valsalva maneuver. The last part of the Valsalva is when the heart rate is highest and the chamber is less full, and that is why you want to conduct that Valsalva maneuver. It really helps distinguish hypertrophic cardiomyopathy from aortic stenosis, because in aortic stenosis, the murmur is not particularly accentuated when the chamber is empty. So when you have the patient stand, the murmur will not increase in aortic stenosis, and the location is somewhat different as well. Hypertrophic cardiomyopathy is typically in the outflow tract lower and at the left sternal border. Aortic stenosis is typically at the right upper sternal border. Now, we're going to cover when to refer. I want you to know that. So, if there is a family history of cardiomyopathy, Marfan syndrome, long QT syndrome, short QT, and any significant arrhythmias, premature sudden death before age 50, even if the cause was not clear, that requires a referral. And they give you some examples. I give you some examples here. If there's a history of irregular heart rhythm, weak or delayed femoral pulse, fixed split, S2, a loud murmur more than 3, or a diastolic murmur, or if there's physical findings that suggest Marfan syndrome, that is an indication to refer. They do highlight this at the bottom of the PPE, so it makes it a bit easier. So always perform your detailed history screening exam. Note any murmurs, the location intensity, and this will help you focus on if this is a problem or not, and if it requires further investigation. Here's a question. A full cardiovascular evaluation is warranted if the history reveals A, recent syncopal or near syncopal event, B, lightheadedness during exercise, C, shortness of breath or more expect out of proportion to the level of activity, or D, seizure during exercise. Well, the correct answer is E. That one's pretty obvious. I think all of those would raise lots of alarms, and that would prompt you to send the patient for evaluation. Now, I want to tell you, some kids do get dizzy when they exercise, and that could be related to a lot of things: dehydration, hypoglycemia, even kids with dysautonomia. But you don't want to question. You don't want to sit on it and say, "Oh, it probably is that," or assume it's just that. Get them checked out, and then you will know. That's my recommendation. Here's another question. A finding of prior restriction from sport participation, syncope, pre-syncope, should trigger a full cardiac evaluation. If recent, all significant physical exertions should be withheld until the workup is complete. So if any of that stuff is recent, do you withhold them from exercise? True or false? The answer is true. Yes, even in that star athlete, where the parent is pushing you, even if it is, if they passed out and it was recent, then a full evaluation should start and exercise should be restricted. All right. Soon I am beta testing a pre-season cardiac assessment tool that I hope to release sometime soon. And once I do, I'll go over that with you a bit more on another webinar. But know that it will help simplify your questions and the processes and when to refer and when not. It is a wonderful tool, and I hope to release it soon. So, in summary, some red flags are here in this nice table. Things that we do once we get the patient, and to determine if this is an athletic heart or a child with a problem. We typically will do extensive family history, repeat some of the things you've done, check symptoms, and compare them. And note side by side here, there, as we talked about, there are a lot of normal things that do occur as part of remodeling. There are few times where we pursue genetic testing, but if there is suspicion, and we've done an EKG, an echo, there are some red flags with abnormal EKG findings, chamber sizes are abnormal, decreased function, dyskinetic wall motion, some changes on the EKG that are non-ischemic but concerning still. If there's a history of non-sustained VTAC or multiple PVCs, left bundle branch plot, we then start to consider could this patient have a cardiomyopathy, and we would pursue more advanced testing like an MRI and maybe genetics. Here's a wonderful handout that you can obtain from the American Heart Association that summarizes sudden cardiac death in young athletes and what to tell the parents. It's in a nice booklet form, and you can hand them out to your patients. Feel free to print this out and put it part of your screening packets when you talk to parents. It's two-part, and it goes in detail to some of the things we talked about today. So that concludes our discussion today. Thank you all for listening. I hope to see you again soon on any upcoming webinars.